Thank you very much, dear President, dear colleagues. It's a great honor to participate at the Israel Heart Society. I'd like to give you an overview over one topic, namely cardioprotection in STEMI patients, really challenging topics and the status in 2016. These are my disclosures. Now allow me to start with a rather personal experience. This was work done in the early 90s at Johns Hopkins when I was a postdoc research fellow, and we looked at myocardial stunning in an animal model. Stunning is the typical example of reperfusion injury, and what we saw in our calcium tracings of controlled versus stunned hearts as opposed to the force development on the lower panel, that in fact the calcium handling was not compromised at all, while the force obviously was clearly diminished. And this was leading us to the point that the lesion would reside at the level of the contractile apparatus, and indeed a few years later we showed Western blot evidence that troponin was degraded in stunned myocardium, as you see on this lane, as opposed to control perfused heart. Now, interestingly, the difference was also visible at a stunned heart versus ischemia, no reperfusion. So obviously, the damage occurred during reperfusion. This was at the time before troponin was implemented as a biomarker in our clinical care. So what happened when it comes to translation of animal models to human studies? I borrowed this slide from Chris Gainger, who called it a graveyard of myocardial protection trials. Indeed, we have not seen any substance emerging that is used in clinical practice as a cardioprotective agent. This important overview a few years ago in the New England Journal pinpointed the major mediators of reperfusion injury. And the first tentative mechanism is shown here. If you have the coronary vessel here, and then an endothelial leak leading to an invasion of immunocompetent cells into the myocardium. Well, we tested this hypothesis in the so-called FIRE trial. This was a trial that used an experimental substance versus placebo, and a number of European centers were involved. The study flowchart was very simple. There was an IV infusion of experimental substance versus placebo in STEMI patients that arrived at less than 6 hours before PCI. And as you see, the study design was very straightforward, either placebo infusion or the experimental substance, and then we followed them by MRI, biomarkers, and imaging, and echo. So this study was in fact showing a few interesting aspects. If you look at the yellow zone on the MRI, it showed the so-called necrotic core zone to be significantly reduced in the experimental group. However, what was really disappointing to many was the fact that LVEF was not significantly different between the two groups, neither at the early MRI nor at the follow-up, as you see here. Well, another tentative mechanism, and I'm sure you heard about this mechanism, is the mitochondrial permeability transition, POR. Indeed, this is aspect that has been tested amongst others by the Lyon group. If you remember the early work on cyclosporine, which was very promising, and cyclosporine has been shown to have an effect on this mitochondrial permeability transition POR. We were fortunate to show this at a ESC hotline session 2 years ago with an experimental substance that is shown here. And this, just by the way, was entirely sponsored by an EU FP7 grant. The study design very similar to what I just showed you from the previous trial, namely the drug or placebo given IV as as a pre-reperfusion treatment one time. And again, we did a number of measurements of biomarkers and cardiac MRI and echo. Now, there is a very interesting aspect. This study enrolled patients mostly in 2012 and 2013. Of all the invasive centers that were involved in this trial, the mean door-to-balloon time was 38 minutes. I'd like to mention this because I think it has an important impact on the interpretation of the result. Well, what did we see? These are the biomarker curves, CK on the upper panel, troponin I on the lower panel, and you see you cannot have a more negative trial than this. Also, if you look at MRI data, we saw that our infarct size was only 15 to 70% in the overall group of STEMI patients. Now, as I pointed out in the previous FIRE trial, you see clearly that LVEF was not affected by this treatment. And I would put forward now that a high standard of care accounted for the relatively small infarct size after primary PCI, and that would leave very little room for improvement. So that brings us to the key questions in reperfusion trials. Ladies and gentlemen, how should future STEMI trials be designed to capture patient populations that actually have compromised LV function? And what I would point to now is the so-called enrichment criteria in STEMI population, and they're necessary in order to allow us to give you a proof of concept. So what should we choose? Should we choose the STEMI late presenters, or should we do a pre-PCI echo, or perhaps a post-PCI echo or a post-PCI MRI to stratify? Should we have anatomical criteria based on the coronary anatomy, or should we pick those who have no reperfusion after PCI, which means perhaps microvascular obstruction? In fact, we have recently shown that microvascular obstruction and infarct size do have prognostic importance in STEMI patients. So I'd like to show you what Dr. Gibson reported last year. Gibson, who just gave an excellent lecture here this morning and who was honored by the society, as you know, the EMBRACE STEMI trial. What is interesting to note here is that these were patients with first anterior STEMIs, and the anatomic requirement was proximal or mid-LAD. What was found in the trial is very much alike the curves that I've shown you from the MITROCARE study, absolutely no obvious effect of the experimental substance. But what I'd like to point to is here that Dr. Gibson and co-workers actually achieved a infarct size that was close to 30%, so approximately the double what our previous trials enrolled. And if you look at LVEF, indeed, it was somewhat compromised. The last nail in the coffin, to put it like that, is the cyclosporine before PCI trial circus. I know that Professor Fausto Pinto, in fact, was on the steering committee of this trial. Now, cyclosporine showed in almost 1,000 patients, which means in a larger trial than the initial reported trial, absolutely no effect on infarct size. This was presented last year at the ESC Congress, and as you see, LVEF was not different in the cyclosporine group versus the placebo group at all, neither at baseline nor at 1 year. So my conclusions are, many modern healthcare systems have established excellent STEMI logistics, including ambulance transfer systems directly into the cath lab, and I know this is also the case in your country. This high standard of care accounts for relatively small infarct sizes after successful primary PCI, leaving little room for improvement. The many failures in the field raise a provocative issue, whether reperfusion injury at all occurs in man, and if it does, whether this type of injury really accounts for a significant part of the remaining infarct. What we predominantly see in today's clinical practice is reperfusion benefit, not injury. And my colleague and me recently wrote this together in the European Heart Journal CEV Pharmacotherapy in our new journal by the title End of Story. Thank you for your attention.